to, and we're being recorded. It's my pleasure, especially to be the NBDPN chair of the board of directors. So I'm really excited to tell you about our board. These are the people that were elected as the board, and you can see in addition to me, there's vice chairs, Maza Yazdi and Vanita Leadham, our treasurer, very dedicated treasurer, Kim Hauser, who is coming to us from retirement, and we're very grateful to her. And then our secretary, Sam Viner Brown, and then our other members, Russ Kirby, Phil Lupo, Wendy Nemhard, and Jason Salemi. And this group is, what I've learned over the last few months, is incredibly dedicated to NBDPN and its activities. And we're especially dedicated to wanting to find out what we can do that will be most helpful to the members of NBDPN. So I said that in the way I said it on purpose. We want to hear about how your programs are doing, but we also know that this has been a tough year for everybody. And especially I can imagine that state and local health departments, that a lot of the perhaps focus that might normally be on birth effects has all gone towards other issues like COVID, since it's been the focus of all of our lives. I know when I was at CDC, if you weren't working on whatever the emergency response was, sometimes you felt like your work didn't seem to be as highly prioritized. So we can go to the next slide. I also want to show the other people that many of them are here, and these are our committee chairs. The data committee, the standards and guidelines committee, program and professional development committee, and Diana is the head of that one, and then communication and health education committee, Amy Nance and Justin Huang, and they have all helped in setting this listening session up. I don't want to spend a long time talking because we really want to hear from you, and I hope that you all will feel comfortable speaking up and telling us what it is that's most important for the board and for the committees to be focusing on to help you in doing your job and to help you in general as we all navigate emerging from this year of pandemic. So I'm going to open it up for conversation, and I'm hoping people will talk. So thank you so much. Thanks for joining us.
Hello. Thank you.
So I think Justin was going to talk next about Brave Space. Is that right?
Yes.
Justin, I should have introduced you. Sorry.
Yes, that's all right. Can everyone hear me? Okay. I'm happy to do this.
Yep.
Okay, cool. Quick reminder, if people could introduce themselves in the chat, if you haven't already, I'll introduce myself here. I'm Ben Huang. I co-chair community or communications and health promotion for the Arizona birth defects monitoring program here. Really quickly then, most of you are familiar with safe space, but today's listening session, we're going to try to maintain what's called.
Sorry to interrupt, Justin. You are a little garbled. I don't know if you can hold the phone different or it is coming in a little.
Is this better?
Not great.
Uh-oh.
Oh, that was
better.
Okay. So let me start over then. Most of you are probably familiar with safe spaces, but we're going to try and maintain a brave space in today's session. There's a shorter history of what distinguishes a space from a safe space, but I'll try and make it even shorter. So basically, a safe space, we're foster comfort, but the problem with that is comfort can start down as soon as someone voices discomfort. On the flip of that, with the brave space, we're trying to foster mutual learning and accountability, which intentionally allows space for breakdown to occur, and then provides a path forward to resolving any issues or differences in opinion. So requiring most of us to feel comfortable, and especially for today, for people who have experiences proposed, we're hoping to hear views to better understand how NBDPN can support. Okay, so here are guidelines. Everyone should speak from their own experiences, own your intents and impacts. And what that means is we're recognizing where you're speaking from, and if you have a reaction, you should be comfortable voicing that as well and expect that. working to recognize our own privileges. The that I do want to highlight for today is taking risks and contributing, even if it's not perfectly formulated. That's what this listening session is for. We want to hear what everyone is experiencing and thoughts are. Take a step back and listen to understand. Last thing is noticing any group dynamics. If people aren't speaking up, if you can from a different program, should feel comfortable in this. Sorry, comfortable is not the right word. Brave. You should feel brave in this space to ask that other person to bring up a topic that you know has been an issue. Okay. With that, we will move with our first question. Next slide. Oops.
So the first one is kind of the obvious open one. Oh, sorry. Go ahead, Justin.
How has your program been impacted by COVID? Be brave.
Yeah, this is Kathy from Massachusetts. I'll start, I guess. Since we have 6 abstractors who had to switch, pretty quickly, not go out in the field, although a lot of our work was remote anyway, but it did cause a lot of, definitely we had to expand that to try to keep up with the work. And I think we did a good job at it. We were able to get into more hospitals than before. So I think that's true for a lot of programs that we could expand what we were doing. And then, yeah, overall, I mean, I think we had a lot of support for doing that. And it certainly was challenging, but I think, yeah, I think it worked for us. We were able to get, keep up with our work. So that was a positive.
Great, thanks, Kathy.
Thank you for being the brave one, Kathy, to speak up first.
And I would like to add, this is Irini from also the Massachusetts Birth Defects Monitoring Program. I would like to add to what Kathy mentioned, except also getting more remote access, even to the places where we couldn't get remote access. We had some abstractors that were willing to go in and still help us meet our goals for closing last year. And also we were able to continue working very successfully remotely and out of the office and continue our efforts.
Thanks, Irini.
So actually maybe some good things that came of COVID-19. Others? Be brave.
This is Lisa from Texas. Can you hear me?
Mm-hmm.
Okay. I want to say that because Texas has already been doing a lot of our extractions remotely, it didn't impact us horribly. However, there were some hospitals that were not electronic and we were not able to go into them to do abstractions. So this kind of threw us a little bit through the loop. Plus the ability of our infrastructure for the state of Texas for everybody to be able to telework resulted in slower connections and more downtime. But other than that, we also got pulled into doing some special abstractions for Zika, not Zika, for COVID. So that also competed with our ability to get stuff done because they pulled from some of our staff, but that's about it.
Thank
A
you.
comment from Arizona too. Some of our work, our direct work wasn't necessarily impacted, but was that never ending unknown. You never know if or when staff is going to be taken or affected, and the priorities that were a priority a month prior, you were kind of tabled and you didn't know when things were going to come back. So our workflow didn't necessarily change, but the broader programmatic conversations and what can we do next and where else, or whether or not resources were going to be taken, obviously funding and staff and all of those things. I'm curious kind of how other programs either move forward or we're stalled with other initiatives. Can't be the only one.
We also here in Utah have had staff diverted to COVID response, some who are actually still there full time. I'll second Lisa's. Moving to complete telework was quite a jump to have happen in a week, and it's taken us a lot of time over this last year and a half to get systems working. Definitely our DTS group here in Utah had a learning curve to get all of DOH and everyone else onto telework. So there were some bumps in the road. I do think a lot of the relationships that we had built because of Zika helped us in COVID as well, because we were able to get those electronic systems working. But again, some of our requests for records and different things were put lower on the totem pole because of COVID and that. So, I mean, we are still working hard to get caught up again, but that specifically for us. And then, like Diana said, I think there were goals and projects that we were working on, but when people got diverted and just the higher ups within the department, just working through those processes, everything was put onto COVID, and we still have quite a few people that is where the emphasis is going. It still is, but it's starting to transition back to a normal, whatever normal is, into the new future. So we're just trying to figure out the telework, telecommute, and that whole, just how that all works for our program and how we move forward in this new age.
This is Vanita in South Carolina. We had our data management support diverted to COVID. So it was a significant hit to us in the sense that there were things that just didn't get done. The other thing is, like Diana mentioned, and like you mentioned, Amy, we've had less foot traffic to our clinics where we were doing a folic acid demonstration project. So because of COVID, there wasn't really a clear demonstration because it wasn't a normal year for people that actually went into clinic. So a lot of it was telemedicine. And so we don't really know what it would have been like if it was a normal year and what kind of folic acid uptake it would have been. It was actually almost completely disseminated, but we think it would have been a lot more demand if there had been in-person visits.
This is Amanda from National CMV Foundation. We haven't had much of the staffing issues or anything like that. We're a very small team, just have 2 staff members, but I don't know, we've kind of had this challenge, a preview of this challenge, I guess, a little bit before when Zika came out, but just, you know, trying to compete with a virus, we're trying to, you know, increase awareness of a very common virus, CMV, and, you know, with another virus kind of taking the front and center stage, I think it's just affected our ability to kind of, you know, get awareness out about CMV, which is obviously super common and causes thousands of birth defects every year, but is not so well known. So I think that's been our main challenge.
I think that's a really interesting perspective because for many of us, Zika was kind of our time to step up and shine. And like Amy said, you know, we developed great partnerships through it. But then you're right, we have so many partners where it was a completely different situation from Zika and then COVID, and then what's next, and how do you continue to stay in the forefront and get your message across? Thank you for sharing that.
Anyone else like to share on this first question, or we can move on?
And we can continue, you know, as thoughts come up, the questions are meant just to prompt, you know, to guide the conversation, but again, it's not super structured. So as we touch on some of the other conversations, it's all going to come back to this as well. So don't think we're done with this question just because we go on to another one.
Yeah, for sure.
They're all interrelated. We know that.
And I'll just take a minute because I am asking the next question. People are still joining. And so if you have just joined, we ask that you introduce yourself in the chat box. If you could give us your name, the state that you're with, and your role within your registry. And then moving on, the second question is, in general, do you have the resources and support to do birth defect surveillance effectively?
And that can be COVID specific or in general.
Correct. And we are trying to watch the chat. So if your mics aren't working and you want to put comments in the chat too, we can watch for them there. So everyone seems to have the resources that they need. Are there?
This is Irene from Massachusetts. So I in general, I would say yes. Definitely, we're very lucky to have the resources and support, but I think we definitely would benefit for more help with abstraction. We feel that as new, like for example, the emerging threats like COVID-19 with or Zika came along, we could have benefit from having more like abstractors that are readily available to take over more work. And we have been able like to kind of deal with that by either like increasing the hours of some of our abstractors that are part-time and increasing their hours. And having like allocating some funding for them to increase the hours, but that was because they had the hours to give. So in general, because abstraction needs are always like very high for doing because we're doing active surveillance, and it would be great like to have more like resources available, like to allocate more abstraction time and have like a team of abstractors available that they can be that they can do abstraction for different like emerging threats or other like adverse birth outcomes that we might want to like work on.
Thank you, Irene.
Hi, this is Dianca from Louisiana. So that question is a little bit tricky. I think we can all say, you know, if we had a need, funding is always very helpful. In Louisiana, we haven't had additional funding to support our surveillance efforts since we had the Zika funding. And so Title V has filled in that, you know, has supported the program fully since Zika funding. And, you know, the program has managed to grow and to get to a great place. And I don't know, you know, if we shoot ourselves in the foot because we've been doing such a good job without the support of CDC funds. I don't know, you know, with this we applied with the last round and didn't get it. So I don't know. I think when the question is, do we have the resources and support? I would say no, we don't. We could use more resources. We can use more support. We're always trying to find a way that we can relieve Title V of the full burden of the program. In an ideal world, we would have that. We would have, you know, CDC funding to help with that.
Yeah.
Thank you for that very honest answer.
And
This is Kathy. I didn't, it made me think when you were talking that there's a lot of funding streams coming now post-COVID, and that are kind of geared toward COVID, but are also meant for broader uses. So I didn't know if there could be some concerted effort to kind of try to identify that for states. Like, I know I just heard my city, for instance, is getting $65 million. Boom, to spend over the next 3 or 4 years. So I think a lot of cities and states are getting monies, but there could be some way because still part of it is people don't know, about these monies, but there's right now is a good time maybe to, try to investigate that.
Great thought. I know that, some states do have environmental health funding. Some states are receiving that ELC funding for Section W. So I hear you in that, the birth defect surveillance side, but I think Kathy's idea of being able to provide, where other states are tapping into besides MCH would be a good thing. And Melissa in the chat also commented that, limited funding is a problem. So we hear that. But I do think Kathy's idea of perhaps, some way of acknowledging those other funding streams.
And maybe NBDPN could create a resource page on that specific, listing out different funding sources that states use. We're fortunate we have a few different partners and funding streams, which just speaks to the partnerships we've developed over time. But really, we've had to get super creative and to be able to share that for other states to say, oh yeah, I didn't know, newborn screening could help or different programs. But yeah, if every state could kind of share different versions of that, I always think our state funding should support our programs, but I know in most states that's not happening. And having a document where we could go and look and just look into different smaller funding streams or sources, or if it's possible to even keep it up to date as new funding announcements come out. Is that something that NBDPN could possibly manage? Thank you, Dianca. It seems like a really simple thing. I mean, managing it is different, but we would just have to ask states to contribute what's going on in their state.
I think that's a great idea, because I think the strength of the network has always been the sort of sharing of ideas across states, and someone might have an idea that your state hasn't thought of. So,
yeah. Oh, that's interesting, Nyla. So maybe looking at Nyla mentioned that population disqualifies them. So looking at some of those alternative smaller funding streams.
One thing too, this is Vanita in South Carolina, is that having a law, like if you don't already have a robust law that allows you to do surveillance, like really knowing your legal partners and what laws you have, because if you have a law, sometimes not only allowing you to do it, but requiring you to do it, it makes it a lot more effective to go to your state partners and say, we have to do this anyway. And, we have a way to partner with you. So I don't know if like the states that might not have laws have had a chance to really dig deep and figure out how they can get policy in place. But that's something that, can happen through partners. Sometimes if you as a state health department employee can't yourself advocate on that behalf, or on behalf of your program.
This is Lisa from Texas again. Interesting that you say that, because I can't remember how many years ago it was, but about 10 years ago, I guess it was. Texas actually went to the legislature and had our law rewritten from a may to a shall, or shall to a may, that actually made it mandatory for that very reason.
That's interesting. Yeah, it makes it harder to say no, right? It's like, we have to do this anyway.
Well, we were in danger of them using the birth certificates, which are really a poor capturing system, replacing us by just using the check boxes on birth certificates.
Yeah.
So Karen, you commented about the 15% cut. Was that specifically because of COVID? Was that just alongside COVID? Was the remote access increase in response to the 15%? Are you comfortable sharing a little more about your comment?
Actually, we were already trying to work towards some remote access when COVID hit, and that just bumped up the efforts. And we now have remote access of some sort, I will qualify that, to 98% of the facilities in the state. And with that said, that can be either direct access to their EHR, or they send us a secure file or something along that line. Again, COVID helped with that, I think, a lot, because they wanted to help us and they didn't want us to come to their facilities, and we were under a travel ban. So it just kind of worked that way. We are state funded unless we happen to bring in a special research project. And the state, due to COVID, cut our budget by 15%. And we're looking to see, we've heard that it won't be cut again, you know, but we're on pins and needles, honestly.
And I guess my comment to the state funding is Utah had previously been state funded, but it also is a line item when the auditors are looking for things. And many years ago, they pulled that line item. And so, you know, now it's kind of covered through MCH. So it's not always that once you're state funded, it's secure. I mean, just like Karen had mentioned, I mean, there was no pandemic, nothing happening at the time our funding was taken back, but it just stood out to our state auditor. And even, you know, with the March of Dimes and a lot of lobbying, we weren't able to get it put back on. So
hopefully that won't happen.
So Allison, right. So Allison also commented on resources with funding, but commented on staff as well. Are your staff needs directly related to the funding, or like I can't hire in my state, even if I had $1 trillion sitting there. I have issues with hiring, and I know other states have that as well. So I'm curious if yours is simply because of the funding, or if you also have kind of that limitation.
I would say it's a little bit of both. Definitely funding is part of that. As far as actually being state employees, we have challenges there. Most of the team right now are contractors. So we're thankful to have them. They have stayed on here for quite a few years. So we're happy that they have done that. But it can be a challenge to keep them. So.
Well, and then contractors cost more. So,
yeah.
I mean, for us, so it then comes back to funding, because you could probably hire more staff with funding you have if you didn't have to pay the overhead that comes with contractors.
Yeah, that's a good point too.
Sam, so how did you mention the prevention services? We are just in the process of working on that for some NAS funding, but that's directly for birth defects funding.
Yeah, so we were able to apply for this specific pot of money. They have a set of criteria. The Prevention Block Grant has a specific set of criteria. Their criteria sort of have a lot to do with disparities, health equity, et cetera. So our service assessment process really works with families to determine what services have been provided, to try to identify gaps in services. So it's sort of, we throw in sort of provider education, parent education, et cetera. So we were only able to, request a fairly small amount, but it was enough to sort of support our parent consultant to do that work. So with the loss of our CDC funding, we were sort of trying to find alternative funding. And so at least we were able to sort of get the Prevention Block Grant funds. And this is sort of like, a stopgap, until we sort of can identify longer term funds for other work. But in the interim, we also, it's affected our staff capacity as well. So it's reduced our staff capacity for epidemiology and abstraction work as well. So
Remind me your structure of where you sit in Rhode Island with birth effects. You're also MCH, correct?
no, we're not in MCH. We relate very closely to MCH, but we have a Center for Health Data Analysis, which I oversee, and the birth effects program, because it's a surveillance system, resides in the Center for Health Data Analysis. But we work very closely with our maternal and child health Title V folks. So we actually reached out to our Title V folks to see if they could also help support. They suggested, we were sort of considering the prevention block grant. They sort of suggested trying that first. And so, next year we're going to also be reaching out to them again for some additional support. So they have in the past helped support our parent consultant funding. But, so we're sort of keeping our eyes open for other sources beyond MCH, beyond CDC to sort of help do our work.
Well, and that's why I asked that, because our MCH also procures a piece of prevention services block grant. So I would have to go around them. So that's why I was wondering if you did that directly or through somebody. That's great information.
Yeah, those sources are those two block grants are sort of managed very separately.
Yeah. So I will say too, and again, I think the document and having, there's an opportunity to kind of do a forum discussion on the website. We have also done community grants through March of Dimes for specific initiatives, mostly geared towards folic acid, but they're smaller, they're not program sustaining, but $10,000 to $50,000 for a project can come in handy if you have a specific goal or structure. So definitely look for those in the community as well. I don't see any other chat comments. Anybody else? The next one is pretty closely. Yeah. So basically any other challenges you're currently facing in your state programs. I think we've covered a lot of them. But if anything, broader kind of comes up. This is a great conversation. I appreciate it.
Hi, this is Stefan from Florida.
Hi.
And I'm an abstractor. Hi, Diana. And I think, aside from the any budget concerns, and since it's not, I can't really speak about budget concerns, but I could say that as an abstractor, challenge would be, as it's been mentioned before, the access to remote medical records, electronic medical records remotely, but also the sometimes some locations just have more security features on their records, and some are a little slower to respond to our requests for help with getting the right records. I would say to lump it all together, sometimes it's a technical issue, and sometimes it's an issue about getting the hospital that we're getting our records from to respond to us in a timely manner.
That's a really good point. I mean, getting access is one thing, but being able to use it and understand it and the technical pieces and how each system or hospital system or EHR operates. We don't get the same trainings that the hospitals get, right? So trying to find specific patients or information, that's a really good point.
Yeah,
Karen?
and one thing I will add is just, for our abstractors, a lot of the time, now that it is the medical record, some of, they use a template and you have to go through and it just pre-fills the template. And so there's many days over and over and over when you're looking through this child's records. I mean, a lot of the same information is repeated, and it will be this one person who says something new on one day that you're looking for, but they just spend hours and hours and hours reading the same thing over and over. And just the way that those templates and just, having physicians just pre-fill rather than write a new note every day. So definitely just how the EMRs are, and that there are so many, and that hospitals continue to change. We have a hospital organization that was bought out and, was on Epic and then moved, and 6 months later is now going back to Epic. So all those processes are really tough.
We had one hospital system that, Justin, I think it's like 8 facilities, and they did a full training with us. It was amazing. They had never, let us do remote access before. So because of COVID, they finally allowed it. And they did this 1.5-hour training with us. They don't understand our work. They don't know what we're looking for. So we started asking specific questions, and the medical records team, they know their system, but they don't know what we're doing or what we're looking for. So even with a full training, we still had to figure a lot out. And you're right, Karen commented on the same thing as Stefan. We're not their priority. They're not responding to us with technical issues all the time. I sometimes hesitate to reach out just because I know what's waiting for me and that I won't get that response. So there's a lot of figuring it out ourselves.
And Amanda's comment in the chat about CMV and working with NBDPN. Amanda, we would, love for you to, we have worked to put out information on CMV through our social media channels, but if you want to join any of the special work groups for social media or any of that, we would be happy to have anyone join and help us in, getting those messages out. But 100%, we're trying, but any social media you would like, huh?
No, I was gonna say, I'm gonna go a step farther and say, Amanda, we can do a webinar on CMV.
Yes. So we're happy to share. I mean, here in Utah, we work very closely with our CMV group, and our health educator, always has CMV information available, and really does, we work very closely together. But anyway, yes, we're always open to working, and please join any committees. I would tell anybody if there's any interest. We have 4 great committees within NBDPN, so many hands make light work. So.
Hi, this is Kathy, Massachusetts. Yes, I mean, many people in this group are on our Instructor Training and Tools Committee, where we've discussed these issues. And one thing I would echo what Amy said that people have discussed is they feel like then the quality of the documentation has changed due to telemedicine visits, which could impact our, it all gets back to then that's the data we collect, that's the data that documents our birth defects. So, it could, we don't know yet because we haven't analyzed it, but they definitely felt like people felt they've noticed a difference. More, like you said, more canned text, things not as well described. So that, I would say that's a challenge too, to try to, if people are experiencing that because of telemedicine, things could be delayed, in being diagnosed is another issue people brought up. So it could impact our rates down the line.
That's a good point. Our data can be affected by everything, and we don't talk a lot about that.
Would be really an interesting study to look before and after COVID to see the differences, because I do think telemedicine, I know that my physical exam on telemedicine is certainly not of high quality.
Yeah, and how many people didn't go for genetic screening last year, didn't go for in-person or follow-up for babies? That'll be really interesting. Our data committee will jump on that.
This is Vanita. I just want to mention or ask a question. So I didn't know this, but one of our abstractors reached out to all of our hospitals. She was brand new, and she said, whenever I started as a nurse, you offer this training for your systems. And they were more than willing. So I know you mentioned, Diana, one of your systems did that, but it was that straightforward that we reached out, and several hospitals are offering this training to our staff for free, the same training they'd give their staff. So that's one thing. And the other thing I was going to just mention is, I don't know if we already do this, maybe somebody knows, but if we had a way to share our laws and legislations. I know we did this at one point. That's, to know what other states do and how they operate. But secondly, also our SAS code for different types of projects. I know those aren't exactly directly addressed through our conversation today, but it's just another way to share resources. I don't know what other people think, but I mean, we would be more than happy to contribute.
I mean, that's a great, as we're talking about creating some resources and documents that live on the website, certainly one for our legislation or our state mandates and rules and things would be, I think that would be something we could openly share, at least links to other states, if not full documents. SAS code, I love. I'd have to, that's a bigger, but yeah, why are we all doing our individual work? And I think that's the benefit of the in-person meeting. And I think that's part of this conversation of rebuilding some of those networks. So managers or EPIs or abstractors feel comfortable reaching out to other states. And just by you saying that, Vanita, other states could potentially reach out to you and say, hey, yeah, will you share that? Kind of rebuilding that community.
Diana, what about position description? Someone reached out, remember not that long ago, and asked for position description. We could send, we could share what in our state, a program manager does, or surveillance manager, or a health educator, so that people can even use those to sort of build up their programs.
Yeah, I've shared interviewed questions before.
Like
I've shared, all of that. You're absolutely. Why are we recreating the wheel when we have however many programs we have across the country and other states?
Hi, this is Kate from Delaware. I'm an abstractor. And just to build off of that a little bit, I know we had something like this in the past, but I don't think it was very highly used. But I would absolutely love to have an area on the website where I could go to when we have questions like, gosh, how do other registries code this? Or what are other case definitions that other registries are using? Just questions that come up that we often wonder, well, what's everybody else doing? So just to have like a interactive area, like a chat room, I guess, where we could talk about things like that.
So we do have the capacity on the website to do like a forum discussion. So we would just, as a network, the board can certainly talk about it, or the operations committee. How do we establish that? And it would need to be moderated. But those are great ideas to just have an ongoing open forum, especially the way things are right now with teleworking and different things, and not having those meetings. I think that's a fantastic idea. And then having a separate resource page on the website. You can tell I don't manage the website, so this doesn't, I have all kinds of ideas. But really to have some documents and resources that are readily available that support that member community.
This is Lisa in Texas. Just one more thought. You asked how it affected us, but what I didn't think of until just now is that what it really heavily impacted was our vital statistics people. And because of that, they're really far behind in finalizing their vital statistics. And that, of course, impacts our program's ability to do linkage and pull certain variables in and lock up our data.
These are all really good points.
I think I agree with others that spoke. This is Irene again, that the access to the hostels, like what they are given access to our abstractors differs from hospital to hospital. And this could create issues to what kind of data they can easily have access to. For example, for some hospitals, we need to like request the autopsy report or the autopsy, the placental pathology reports. And also like not only like the full access versus limited access, but also like the difference in different systems that they're using and how they can navigate them. And one way that we, in our like surveillance, we have tried to overcome this is by trying to do like during our meetings, to try like one abstractor or the abstractors between themselves sharing tips how they can navigate the different programs, like the different systems, like Epic system versus another system, and where they can find the information easier and quicker, because also like finding the information like quickly and knowing where to look, especially like in the new systems that are pages and pages long, it is important.
Definitely. And I know we have a few people that have already spoken from the abstractors work group, but I think some of that, we've done some overviews and training to help with some pieces of that. Of course, it doesn't help navigate the different systems, but trying to streamline the abstraction process for sure. Yes, so we've talked about a few of them. But really expanding on that, we're so good at talking about our limitations and the negatives, which is important. We need this safe space, brave space to vent. But really, let's reframe it and talk a little bit more about the positives, like I said, with Zika, it was easy. And then COVID is a whole different thing. We talked about some remote access and other positives. I'm going to go ahead and throw in there that while it hasn't been immediately and quickly received, I've been trying to move the conversation of let's talk about COVID in pregnancy. Let's talk about the vaccine in pregnancy. And so even though it hasn't been easy or quick or always well received, it's been a new way to keep our program at the table. And going back to speaking to like Amy talked about the partnerships that were established. We're not directly involved in COVID right now. Fortunately, I have all of my staff back, but keeping us at the table and part of the conversation, because we do understand more about potential outcomes than some of the other programs. And even if we don't have the capacity to look at it right now, we're still involved in that. And I think that's a positive. It'll be interesting to see where it goes. I know there's conversations in other states and at CDC, and some states are already working on it. But I always value any of those conversations and partnerships we can be involved in. And specifically with COVID, because it's so new and unknown, all of those conversations are happening.
Yeah, this is Kathy, Massachusetts. I think as painful as it's been this whole period, I think one thing I think that our department has been very supportive of is the racial reckoning, and it's probably because of COVID having a disparate impact on communities of color. Hopefully, a lot of that is being addressed. That there's a lot more attention to learning about the history of things, and then also addressing the disparities that exist, and room to do that, because you think, oh, I don't have time to be taking this 2-day course, but there's support for taking a 2-day course, so that's been positive.
That's great, and something completely unexpected through a new pandemic, right?
So I feel like we're sharing, or I've shared quite a bit. There are several other people on the call. Does anyone who maybe has not had the opportunity to share yet have a thought on this? Positives?
This is Lisa in Texas, and then I'm going to shut up.
No.
I do want to say that I think it has opened the eyes that business practices do not necessarily entail you have to be all in the same building all together. You can actually work in a less traditional kind of situation where people can telework in. And I think that that really is going to have ramifications for the future and how business is conducted. And I think it's a positive thing.
Yeah, I can second that here in Utah. Our abstractors have been, wanting for a long time to try to work teleremote, and it was a scary thing. And then when we were pushed towards it, it actually is a benefit. They're reviewing cases faster. I think there's less distractions, and so it in that way has been a benefit, and so a good thing.
I'm curious, and this goes kind of to this question and the previous questions. How are our states, are you guys starting to have the conversations to transition back? Are people that were 100% or mostly remote, are they coming back, or are people staying remote now that that's been established? How we've done things, like you said, Lisa, and it's opened the door for all of that. But where's that going?
Oh, sigh. I was going to shut up. This is Lisa in Texas. They're
Don't be
starting to
sorry.
talk about.
No, don't be.
They're starting to talk about, quote, reconstitution. I don't know if that means they're going to add water and we're going to plump up or what, but they are talking about bringing people back to the office, and they're being more open about teleworking, but by the same token, they still want to have warm bodies. So the conversation has started. What's the end result? I don't know yet.
Yeah, in Utah, we started our transition back June 1st. And there has been a big push for people to stay telework. In the midst of COVID, nearing the end of COVID, they actually sold one of our health department buildings that we were in. And so at the beginning of COVID, we had moved into a new building, and at the end of COVID, we have moved into a new building. So 2 moves during this last year and a half, but definitely telework. And now here in Utah, we're having what they call surge days, which are like mandatory action days because of the weather and inversions and the pollution. And our governor has been very our new governor is very forward thinking and has legislatively mandated that if you have a telework or telecommute contract, that you have to surge on those days. And in the last 2 weeks, we've had 4 surge days each week. So even though we're coming back, we're still teleworking.
Has anyone had any resistance to either teleworking or returning to work? I think everybody has very specific opinions.
Looks like in Louisiana, abstractors will be 100% telework and visit the office 2 or 3 times a week. Oh, they only visited 2 or 3 times a week.
And Nyla has her own set, yeah. We have learned different ways to work, right? And at first virtual meetings were not good. Now we get excited when we see people's faces and things, and we're adjusting to technology. And okay, yeah, a lot of transition.
Yeah,
I'm generally in office 2 days a week, and yeah, they're fantastic. Happy to balance it by being home, but it's interesting.
I think what this has given us is the option. I've had a lot of my staff, just the flexibility to have the options to telework or telecommute and what that means.
And I'll say, I think it's also given people an opportunity to figure out what works for them. Not everybody does great in the telework setting, and not everybody does great in the office setting. So really, I think we've been forced to do both at times. And so now I'm hoping moving forward, we're really able to look and use our staff strengths and let them do what works best in a modified capacity, trying to manage a program. But hopefully moving forward, we get to listen more, which to me is all positive. So bringing it back to the question on the screen. So we want to broaden this a little bit. Yeah. Let's
One
go
more.
on to the
Curious to know if any state has remote staff work out of state.
We do in South Carolina, but we are not allowed to make them FTEs. We can only make them hourly.
Oh, that's interesting.
Yeah.
You can do it by contract, or?
So we can do it by contract. Yeah. So if you have a contractor out of state, they just can't be a state employee. But it's been kind of tricky, and COVID sort of changing the landscape of it.
Interesting. And Nyla said the same thing, that's under contract.
In Utah, there was a law just passed by our governor that if you are teleworking, you can't live outside of the state. So
that was a law that was made.
Yes. He's from a very rural area in Utah, and he really wants work to go rurally. But that, those who are working telework should not be out of state.
So what if you had somebody that worked for your state and then chose to move, they wouldn't be allowed to work for the state anymore?
No, we actually, that is, I know our EI program had a therapist that was doing remote visits, and since that's kind of the way it's moving forward, and during COVID moved to Wyoming, but they had to terminate her employment because she couldn't continue to work within that program.
So then I wonder how many people just don't update with their location. And to throw that out there, but yeah. I'm sorry, I think Benita was talking. I heard a voice.
Oh, I think it was
No,
me.
I wasn't.
Oh, I heard a third voice. I wasn't sure.
Thanks.
So Washa, I'm sorry if I don't say that right, made a really good point. Because of the different environmental factors, it will be interesting to see if anything was decreased or changed, or were people not accessing folic acid, so we see an increase, or they weren't accessing prenatal care, so do we see an increase, or because it was, air quality, water quality, stay at home, probably getting more rest and things like that. It'll be really interesting to look at the rates over the next couple years, not directly related to COVID.
There are some data that showed decreases in preterm birth related to the lockdown. So it should be interesting to see if we'll see any of those differences for birth.
Yeah, this is Kathy. We met with our prenatal people who report to us prenatal diagnosis, and they said a wide range of things, but among them, I think they were seeing some things were being diagnosed later in the prenatal period, which could have implications. And then also they found that women and families really liked teleworking, telehealth genetic counseling. It somehow made it a little bit, they benefited, they thought they really liked that, to do it that way. Maybe it made it easier when there was bad news, or it was just, they could have their family there. And then the problem with being pregnant women, people couldn't be with them, but then if they had a televisit, that would, more could be with them when they were discussing all those issues.
And we've seen that with early intervention. We've seen that with home visiting, that more states seem to have, or more clients that weren't necessarily participating are engaging in services. Or I've also heard with intervention where people didn't want providers coming into their home because that was their home, and they didn't think it was good enough to invite people into their home, that they're now accessing services because it's just a screen. So it'll be interesting moving forward. Hopefully we continue to engage and do things with what works for people, because we have all of these opportunities. And yes, Stefan, I agree. We're all excited about hoping for some travel in the next year. We get to go somewhere and do the pieces that we do like, because interaction and community and all of that. Which kind of leads into our next question, if nobody has.
The next question is, how are you and your staff or family, peers, communities dealing with some pandemic-related stress?
So really going to that broader question, like, aside from direct work, what else is going on?
I didn't want to speak a lot, but I think for some people here, at least, childcare has been an issue, and how to navigate the changes in childcare.
I can't imagine the multitasking of having kids at home and trying to do work. There's a lot of discussion in academics about how it's going to derail many young women's careers. And I'm interested in what sort of impacts that's had on, a lot of people in birth defects are young women too, so.
I'll just say I'm thankful for the mute button and the stop video button. Oh, I love that. Dianca, right? Dianca, how do you say? I had it when you said it the first time. Talk a little bit more about your mindfulness sessions. I love that.
Yeah, so our agency's implemented Thursday mindfulness sessions. So we have folks that conduct them, and people are able to join in and spend just a few minutes, being mindful and going through that process. And it's really just, I guess it's a time where we all can kind of breathe, come together collectively and just breathe. And I say agency, so it's not even, it's not our birth defects program or the bureau that we're a part of, which is the larger entity, or even the center, which is larger. It's the entire Louisiana Office of Public Health who can participate in this. So it's awesome.
That's wonderful. That's amazing. Yoga has been instrumental in dealing with pandemic-related stress. Yes, exercise for sure. And I've talked a lot too, and I'm sorry. Just here in Utah, I've reminded my staff, all of my staff multiple times, that we're all in different places and spaces, and we need to give each other grace. And
I'm assuming that the doctor probably got there late.
And just know that if someone snaps or something happens, that we're just all in different places right now, and just we try to work through those types of things, and that this teleworking has been hard on people, so, and not so hard on others. Others are thriving.
And I've really tried to be flexible and encourage that. And it was interesting watching different staff try to adjust to teleworking, where we try to have some structure, but then really encouraging, take a longer break, go for a walk, go do something. Don't think that you have to just do this, 30-minute lunch and come back. Like, go. And Justin can comment. Sorry, Justin, to put you on the spot, but I think over the year, staff has adapted to that and accepted and really taken the opportunity to do that. If you have an hour in the afternoon to spend time with family or do yoga or do the mindfulness sessions or whatever, it's okay to have a little bit of a flexible schedule. And I personally hope that we can take that into the next year as we return it and go back to a little bit of normal.
Yeah, I can add to that. Part of it is being able to telecommute is great. I've been enjoying it mostly because I don't have to take the hour-long drive both ways to get into the office. And so being able to take the extra time, like a longer break or whatever, during the workday doesn't increase the amount of time that I'm away from home and my wife. And we do get more time that we get to spend together too. So it's been really enjoyable for me.
Meanwhile, I'll see you in office this week for the first time.
Right, yeah.
So Karen shared Thankful Thursdays in the chat, where they have each share at least one thing that they're thankful for. Just a way to bring positivity. And then, yes, Nyla, it has been a hard year. Yes.
And to not have the support systems we usually have when you do go through the loss. Normally we can grieve together and that's not happening. Yeah. And honestly, that was part of this conversation today, not just talking about programs and staff, but we are a community. You know, obviously we have some pretty big things in common. And the more we talk and have these conversations, we realize it's not just at a programmatic or professional level. We do similar work because we have similar passions or interests or strengths. And I mean, I very much appreciate seeing people's comments because you realize you're not alone in any of this. We're all dealing with a lot of the same stuff.
Lisa in Texas. I just can't seem to shut up. An interesting sideline of this is that the air quality kind of improved because I don't know if you read our lovely I-35 was rated one of the 10 worst roads in America. And because of all the people who were telecommuting, there was considerably less traffic on the roads. So infrastructure wise, it's had impacts in the community.
Yeah. Danita, you have your hand raised. Oh. Is there anything else anyone would like to share on this question before we move forward? Okay. So the next question is, are there ways that NBDPN can better support you and your programs both now and post-COVID? I think we've talked about a few. The board about funding, perhaps, a chat area for members to ask questions, but are there other things that people can think of that would be helpful from NBDPN?
I really liked hearing some of the ideas for sharing of resources. So if there's other ideas for that, I think that's what this group is all about, is sharing resources, sharing ideas. So more ideas like that would be great.
Oh, I like that, Jody, too, sharing kind of what is going on within your program. And that's something, one of the questions, so from the network, we do have some ideas that we're trying to bring to the membership. So we don't want to feed the topic or the question and give you the answers, but you know, was this session helpful? Just having the conversation. Do we want to do more of this? Is this something that you guys would want us to do more often, whether it's moderated and structured with questions or really just an opportunity for conversation? There are some things we're trying to put in place, and I don't know if we can show the next slide now with some of what we're talking about and get feedback. So the session that, like sessions like this, do this, you know, 4 times a year, quarterly or something. We are working on some of the program managers calls, the mentoring sessions, or the program sessions. So, and yeah, you're right. If we develop that forum, then we can have ongoing conversation. We can talk more specifically about some of these, but feedback on what we're doing or what you need.
So I'll add in one thing. There used to be like a young EPIs group that met probably not pre-Zika, but 2 meetings ago, I think it kind of got started. I do think that would be a great resource for some of these new professionals coming in. Sometimes, you know, some of the bigger groups can feel a little daunting. So having people who are starting in the same area, I think is great with some leadership from more seasoned EPIs. So that would be one thing.
Was it like a subset of data committee?
You know, I don't know if it just kind of started. I think Sarah who works with Barbara had started it, and she's definitely been moved to COVID. So I don't know if that's one of the reasons it stopped, but I know I had it, our EPI before really enjoyed that group.
I just want to mention too, it's for any EPI. So like if you are new to birth defects, but you've been an EPI for a long time, you can also join it. I'm sorry to like.
No, 100%. Yeah.
It sounds like, I know what you mean. Like, yeah, exactly. But I just wanted to clarify in case somebody's like, but I'm not a young professional. I just switched into birth defects, you know? Yeah,
I
sorry.
think the conversation was because like the data committee is intimidating to new staff. That's the side I always heard. And so it's like, how do you just jump in when they're having these conversations that everybody's been a part of and everybody knows what's going on? And then you have peers that are doing exactly what you're doing, right? And so how does that, yeah. So that's a great suggestion. So some of the things that we do have coming up, and again, please add to whether you think they're valuable or whether you can think of something else.
I mean, one of the things, are there other webinars that people are interested in? Is this more webinars than you have time for? Would you rather have more kind of social sessions? That's what we're really trying to figure out. What can we do that can be the most helpful to members right now during this sort of strange time when we can't be seeing each other and getting to know each other in person?
Right. Thank you guys for the positive feedback. We appreciate it. And if it's valuable, we'll definitely continue to do it. The webinars we currently have planned are definitely to be more educational, starting with the CCHD webinar in September. That will be a 3-part series. So it'll be kind of the overarching view of CCHD and pulse ox screening, a more specific kind of anatomy, physiology focused one, kind of what and why we screen for, and then more of a state perspective. So trying to bring all sides into it. I know there's a lot of conversation around NAS, so we're working on one for that, or possibly multiple. And then going back to the earlier conversation, some kind of talking about disparities, both in practice and in intervention, but also specific to data, to kind of some of our work. The member meeting, annually we have a meeting of our membership, so that will be happening in November. More will be coming out about that, and that's open. It's not any specific role. I think we tend to have our managers or our higher level staff participate in stuff sometimes, but these are for our NBDPN membership, just like this conversation today. And then opportunities to let our program and our work shine through Folic Acid Awareness Week, which is moved to September, and Birth Effects Month, which we'll talk about. I paused. Go ahead, Amy and Justin. And also remember, you can chat through, we'll keep this open for a few minutes even after things quiet down, and feel free to chat ideas. And there's also ways to email NBDPN through the website. And I think we have that up as well in a minute.
Yeah, I'll share that. Go ahead, Justin.
Sure. So this has been a conversation for the last couple months on our planning committee, at least, or the work group, not committee. But it was raised by some of our CDC partners to change the naming convention for Prevention Month to Awareness Month. And I spent some time reaching out to some of our other partners, the American Academy of Pediatrics, March of Dimes, who else? Mother to Baby.
Yes.
And most all of them are like on board with CDC's lead. And so we are also considering a similar shift in our language for that January month of awareness. We do want to hear from some of the program managers as well. Is this something that you would be able to jump in on too? Is that something positive, negative? Any feedback is helpful.
So I think all of us understand what the intention of Birth Effects Prevention Month is, but I do think what we were hearing from some places is that sometimes prevention, and certainly I heard this when I was at CDC, that sometimes prevention is seen as pregnancy termination, which obviously has a negative connotation. So I think that's where the idea is coming from, to change to birth effects awareness. Of course, awareness includes prevention when it's preventing a child from having spina bifida because their mom gets folic acid. And we wouldn't want to diminish that. But do people have concerns? Anybody feel like this doesn't really represent what we do? Very quiet. Anybody think it's a good thing? Still quiet.
I can see the positive and the negative. So maybe this will get some other groups too. Okay, we're getting some feedback of awareness. I've spent so many years explaining why it's prevention, that it's not preventing of people or conditions that can't be prevented, but we're trying to improve quality of life and prevent, secondary and tertiary issues, prevent death, prevent other things. So I've tuned myself to the word, because I've flat out been yelled at by communities of saying, well, a lot of good that does for me. No, yeah. We still want you to have, a good life, or, we want your mom to have a healthy pregnancy, regardless of a diagnosis. We want to promote positive, healthy pregnancy so that whatever outcomes happen, we're ready for them. But having had these conversations multiple times, I'm coming around to awareness, because I get that we can do a lot with it. No, you guys are getting a lot of I'm reading, sorry.
This is Irene from Massachusetts. I mean, I like both. I like the National Birth Effects Prevention Month because it is immediately related to the National Birth Effects Prevention Network, and it seems that it's an effort coordinated by the network. Maybe you can combine both, because I can see both being equally important. And if you are considering changing, and if you think it is important to include awareness, maybe National Birth Effects Prevention and Awareness Month, so it is inclusive in both ways, because there are people that certainly feel that prevention is like important for them, like not to have, and others that they feel that secondary prevention, like having a good life, etc., after like a birth defect has happened, is also important. And bringing awareness to the lives of the people that have been born with a birth defect is important too.
Yeah. Thank you.
And we did talk about including both in the name, but that really gets long. And so we heard, I know there was some negativity associated with that. Oh, so Sam, you guys already did it. You went on your own.
Yeah, we did it actually quite a long time ago. It was, I think it might have been one of our first birth defects prevention months after we received our grant and became a program. And we were putting on a sort of forum at our children's hospital where we had grand rounds and poster session, et cetera, and immediately received some feedback from the Down Syndrome Society of Rhode Island, who we had sort of partnered with in advance of that grand round. So, you know, we just decided that we thought, yeah, and other folks had also given us similar feedback. So we just decided, just in Rhode Island, we called it Birth Defects Awareness Month.
Yeah, I think that is one of the groups that I found that I worked with a lot when I was at CDC, that I think really found the prevention term very offensive. And we actually had a large meeting to plan for future research in the area of Down syndrome, and ended up taking the section, the whole discussion of prevention out because of that. So I think even though we were thinking of prevention of secondary disabilities, that was not the way it was interpreted by families. So Sam, I think we had some of the very same experience, so thanks.
Well, thank you all for sharing thoughts on the prevention versus awareness. Obviously more to come. And we will let you all know what it ends up being. Let's see.
So these were just some of the plans that we've been working on for as part of the board. I didn't want to go into these in detail because we really wanted this to be a listening session. It does seem like people are starting to need to go on to other things, and I actually have a 3:30 meeting too, but I did want to say how thankful I am. I can't believe 45 people signed on. This is really wonderful. We'd love to hear more from you. I know some of you may be shy. I'm always shy on these calls. So, you know, we are happy to keep listening by email. So if you have thoughts, please send them to us. If you didn't feel like you were comfortable talking in front of the whole group, or even putting something in the chat, please email us. We really want to hear from you. We want to hear what we can do that will be the most help to your program and also to you. So please keep in touch, and we hope to be seeing you on one of our future events soon.
Thank you.
Thank you.
See you guys. Bye-bye.
Bye.
Bye.
Thanks, everyone.
Bye-bye. Thank you.
Thank you.
Bye.
Thanks, Justin. Whoever's idea this was, it was great. So thanks so much.
It was.
It was really excellent.
Thank you for
I'm following the chat for a few minutes. So
yeah, I was doing the same. I was doing the same.
Great feedback.
Yeah.
Definitely. I think people want more.
Yeah.
This kind of conversation. So
yeah. And I think as we do, if we do it again, I think people will feel more open the next time. So to see that there wasn't any, I was glad that there wasn't anybody saying, oh, no, don't do that. You know, there weren't any negative comments. So that was really good.
Yeah. And some
So
really
people could
great
be brave.
ideas.
Yeah.
Right. Yeah. And Justin, I saw you taking some notes. So thank you. But I did record it, and I will also take a file of the chat just so that we can look at that.
That
Yeah,
sounds
I
great.
was gonna say maybe we don't necessarily have to listen to the entire session again, but we could certainly listen through some pieces and make some better notes.
I didn't know if we wanted it, and I mean, we had talked about it briefly, but it didn't start on its own. So
yeah. So that's wonderful. But thank you so much for setting this up. This was great.
Yeah.
Hi, guys.
I know you have another meeting.
Yeah, sorry.
Yeah.
Yeah.
We can
All
keep
right.
chatting. Trying to figure out who's still on.
Yeah.
And the phone number, because she's Leo.
Well, yeah, you're the phone number, right?
Okay, so we just lost the other person. She wasn't paying attention. Hold on. So Kim did message me in the middle that said we could set up a forum, but again, it would have to have a moderator, which I feel like somebody from the board could do.
I mean,
I don't know. I'm just thinking.
Throwing it out there.
If we set up a document, like a resource document, like in the next newsletter, could we send something out and say, hey, based on the listening session, we invite you to do this? Could we do that and then create a document and have it live somewhere?
I mean, I think we could definitely add a page. I mean, maybe this is something we only want on the member side. That was one thing I was thinking about.
That's what I was thinking too. It's a huge member benefit.
As well as the forum, you know, I mean.
Absolutely.
That's our problem, is pretty much everything is available to anyone.
No, I 100% think they should be member only. I mean, you're right. We need to have more member benefits, and this is a very obvious and specific one.
Yeah.
Especially if we're sharing things like code and job descriptions.
Yes.
I mean, I think we caught most of it between us, so I don't know if we have to listen again. I just don't want to like.
Yeah, I mean, I don't know that we have to either. I just didn't know, like.
So I was
wanted
gonna
to be
say
appropriate while other people were on the call.
Yeah.
Yeah.
Like. Up. And it just like.
You're breaking up just
Yeah, I can
maybe
hear
just
you,
for me.
Justin.
Better, worse?
Are you talking?
So maybe we set up, I'm sorry. Maybe we set up a conversation with Sonia and Vanita and Masa, like, or somebody besides just OC.
Yeah.
So it doesn't come back to us specifically, or with the entire board. And we say, you know, based on the listening session, we want to propose this, this, and this. And we kind of put it back to them. Or a document. I don't want it to all come back to us. They need to step up.
Yeah, I don't want it all to come back to us either.
Somebody from the board can moderate this forum page.
I mean, yeah. obviously it will probably get put onto Vanita and Masa as the real worker bees perhaps, but I mean, it is bigger than us because questions could be asked of all areas, not, you know.
Mhm.
Right.
But then there has to be a description of what, you know, what the moderator does, how things are handled.
It feels like it could just be if somebody brings